related to major lung thoracoscopic resections in children.
So we analyzed morbidity after major lung duct resection in older children. In our population of 22, we had more than 80% of patients having had respiratory symptoms or previous infections, and more than 65% having an active infection. Our observed rate of postoperative complication, according to the thoracic mobility system, was of 54%. And the predicted risk from the available online calculator from ACS, was of 4%. This huge difference was significant, and more importantly, the predicted risk was not associated with a higher chance of having a complication. Our observed rate of complication might be overestimated by the 41% patients with recurrences, and the predicted risk might be, on the other hand, underestimated, probably because it's not taking into account some specific thoracic features such as athleticism and bronchoscopy. Moreover, our observed rate and predicted risk were higher in the predicted population, but this has to be confirmed in the larger population. Statistical significance. Sorry. Thank you.
Okay, thank you very much. Any questions? No questions. I think we should continue for time's sake.
Group from Marseille, is he presenting? No? From Marseille?
Yeah.
Yes, please.
I'm Nicoletta Panay.
Okay, Nicoletta Panay.
She had a setback. So, dear chairman, dear colleagues, we thank you for the opportunity to present our experience on laparoscopic repair of Morgani hernia, and also to make using the extracorporeal subcutaneous knot tying with a review of the literature and to search for the risk factor of recurrences. This technique was first described in 2003 by ASI. I'm sorry, there is a mistake in the poster. And for 8 years period, we had 8 cases, 2 with Down syndrome and cardiac malformations. Only 1 was operated previous to our surgery for the cardiac malformation. And this one has a recurrence at 17 months after the surgery. In the literature, we found 26 articles with 156 patients. 10 had recurrences. By these 10, 9 had also Down syndrome, and also in 2 cases they used absorbable suture. So we think that the recurrences is more often when Morgani hernia is associated with Down syndrome, and also the use of absorbable sutures. And it would be interesting to talk, especially for the patients who had Down syndrome and previous cardiac surgery, to use a non-absorbable prosthetic mesh because to release the tension on the diaphragm. Thank you very much.
Thank you. I'm sorry we cannot get on the question because the time ran out. Sorry.
I've done my best.
All right. So we go to the next speaker. My paper is Valerie Atesta, is that correct? No? And then Mehmet Aga?
Yes.
So Mehmet Aga, modifications of laparoscopy-assisted Morgani hernia repair, mesh reinforcement and knots.
Good afternoon. I'm going to for our modification. You know, for a long time now, Darkenberg hernia in 5,000 live births. The aim is to present our modification. In the past, we do like this. This is defined in the past. Between 2010 and 2022, we had 10 patients. We accept our patients. What is our modification? We cauterize the peritoneum around the edges, but if necessary, release the falciform ligament. Two square polypropylene mesh was used. It was supported the knots and diaphragm. Here is the photographs of our approach. You see the falciform ligament as defect. Similar to laparoscopic assisted, but after first suture, we put in a non-observable mesh to the abdominal side of the diaphragm. And at the end, we have 10 patients. 3 of them was modified. The others are different styles. But we didn't have any complication with these ones and recurrence. We believe that mesh works as a second layer without impeding the diaphragm contractions and it reinforces the knot and diaphragm. On one short and 2 long-term results about mesh reinforcement repair is encouraging for us. Thank you.
Okay, thank you very much. As we noticed, 1 minute is very short, so we have to continue. Sorry.
We're sorry about that, but otherwise we will stay here overnight. So please, the group from Bergamo and Health Recovery, Dr. Valeria this time.
Thank you for the introduction. Today I will talk to you about therapeutic management of the patient affected with spectrus excavatum or developed minimum residual diabetes. Myopa technique is associated with severe postoperative pain. In order to achieve rapid recovery, we standardize a protocol about therapeutic management. Around 20 years, we treated 53 patients with underlying down-regulation psychological counseling for the preparative treatment. Concerning postoperative treatment, here I can show you a summary chart. Payment was effective and allowed the rapid patient mobilization, which we believe is essential to reduce complication and long-term pain. So we were able to discharge the patient after an average time of 8 days. We believe that an effective pain management protocol is the basis of the success of the next procedure. But it's the most important to conceive and follow an enhanced recovery after surgery pathway that includes and promotes a faster recovery and a reduction of hospital stay. We are beginning also to introduce the analgesia of the customers in combination with epidural infusion. This probably contribution. Thank you.
Thank you. Time for a question. We don't have the mic.
Very short.
Yeah.
So I would like to congratulate because ARS protocol is very important in Pertussis forward. So, but I don't see so when you use the cryoanalgesia, you don't need to use epidural infusion. But just
I knew, but for our experience, we are just beginning. We've done 4 cases, and we do the procedure intraoperatively. So during just before the spectrus excavatum repairs, so from our experience, this is necessary, at least for now. Because
so if
it
you
was
use
too
only
high.
cryoanalgesia, you don't need to use epidural catheter, but because the patient requires a bladder catheter, so you don't need to.
And
Only
then
cryoanalgesia is enough.
the anesthetist uses the epidural infusion during the operation because we saw that it's necessary a bit more time to give the analgesia working.
Thank you.
That's our experience.
Thank you very much. All right. Next speaker, will be Anton about serious neurological complications after movement in basic practice with excavatum operation.
complication connected with MIRPER procedure can occur during or post-operation. We report the case of 16 years old patient with symptomatic pectus excavatum with positive finding on cardio MRI as shown here. We performed standard MIRPER procedure under general anesthesia with epidural analgesia. But on first postoperative day, patient developed weak tryparesis with acute transverse myelopathy ranging from C1 to T11, as shown here. Interestingly, most serious changes was in cervical region. 10 months later, patient improved his neurological status due to intensive physiotherapy. He is able to walk on crutches, but there is still persistent problem with micturition. On control MRI, there is significant regression of spinal cord edema reduced to C5 to T2. There are just several case reports in literature which deal with similar problems, but unambiguous etiology is usually not found, likewise in our patient. Thank you for your attention.
We have 10 seconds per question. What's the take-home message for this? It's very important what you show. So, what's the take-home message, please?
Thank you for the question. We still do not know where the problem was, and I was discussed this problem 2 weeks ago with Professor Nass and Professor Kelly from Norfolk, and they have two very similar cases, and after the second one, they stopped completely epidural analgesia. So,
Thank you. Thank you very much. The role of Dr. Pablo Omanik.
my colleague.
Okay. So she is Dr. Kazlov. Please.
So, dear ladies and gentlemen, let me introduce you the role of anthropologic measurements in pectus carinatum based treatment evaluation. It's a prospective study which analyzing 47 patients who are wearing custom-made chest compressive brace. We recommend 8 hours per day. The undocumented measurements are taken from patients by height, weight, and so on, but the main value is thoracic index, which evaluated from sagittal and transverse diameter chest, so of the chest, and the range between 71 and 77 is for physiological bulging chest. But when thoracic diameter is relatively large in coloration with sagittal diameter, it shows us a special form of pectus carinatum flat thorax configuration. In our results, we conclude, I can say the custom-made chest compressive brace offers significant improvement of the chest wall configuration in compliant patients. There are comparable results of symmetric and asymmetric pectus carinatum, and also the patients with circular chest configuration with statistically significant better improvement of thoracic index in comparison with patients with flat thorax configuration. Thank you for your attention.
Thank you very much. Short question.
30 seconds. It's quite good time.
I have a short question. Maybe comparing with literature, is it not short, 8 hours?
It's the average time. 8 hours. Some literature recommend 6 hours to 10 hours. but we have significant improvement when the patients are wearing the brace for average time of 8 hours per day.
Thank you. Okay, we go to the next speaker. So I will invite Revati Menon. Yes, please. She's going to talk about thoracoscopic repair of iatrogenic bronchial injury in a neonate during bronchogenic cyst excision.
Good evening, everyone. Our case is a 15-day-old male child who was diagnosed with severe tracheobronchial malacia, and for the same he was referred to us for management, and he was taken for thoracoscopic excision of radial cyst. The challenges we had to face were that the patient had a very rigid and small working space with structures continuously in motion, and we made it a point that we would avoid injury to the esophagus, esophagus, or the bronchus. As part of the surgery, once we had dissected the pleura, we were able to visualize the cyst, but unfortunately there was accidental injury to the left bronchus, which was noted when there was excessive bubbling and desaturation during our surgery. So we proceeded to repair it immediately using proline 5-0 and there was absence of leak confirmed with no bubbling during our ventilation, at which point we were successful with our repair. The patient was kept electively intubated for 4 days and he was extubated afterwards. We were able to discharge the child successfully 2 weeks since the operation. And in conclusion, I would like to say that the coordinated and timely effort with the anesthetic and the surgical team were able to help us tackle this complication thoracoscopically without the requirement of conversion to open surgery. Thank you.
Any questions? So, which anesthesiological problems did you had during closing?
Basically, the anesthetists were not able to ventilate the child properly once we had caused the leak. So there was quite difficulty from their side, and only once when we were able to suture the leak and completely close it, then they were able to ventilate the child. There was increase in ETCO2 as well, which they had reported intraoperatively.
Okay, thank you.
Thank you so much.
I think there should be a change on the program. Can they? Yeah, that is not on the screen yet. Okay, please, Dr. Patti. She's going to speak about minimal approach for intestinal atresia. Please.
Thank you for the opportunity. The study report our experience in the treatment of the intestinal atresia with the minimal invasive approach. In the last 2 years, we approached 10 cases with the video-assisted technique. In particular, we used a working camera to investigate the aphasia, and then we resulted through the minute incision to do the anastomosis or the tapping. The post-operative course was uneventful. The patient started eating on 4 post-operative days. According to our experience, we can consider the minimally invasive surgery an important instrument in the intestinal atresia treatment because it permits the division of the abdomen, so the individualization of the type and the extension of the atresia, and therefore it permits a good vision, a better post-operative course, and a better an excellent aesthetic result because the umbilic incision became invisible because with the natural photo of the umbilic. Thank you.
One of the criticisms of the treatment of minimally invasive for atresia with laparoscopy is the chance of missing some further atresia. What's your approach about that?
Yes, the combined approach for avoiding the best thing because combined the skills of a surgeon with the possibility to do the anastomosis, that is the most important and difficult part of the of the operation in the open procedure that are more comfortable and traditional techniques that are
I can see the feeding tube, so you flush the bowel below the atresia, right? So to check the rest of the part. Yeah. Thank you.
It is a lab assistant, not a result.
Yeah, it's lab assistant. Ma è meeting was. Thank you very much.
Okay, we go to the next presenter. That will be Enas Ramel. She's going to talk about unique presentation of ectopic parathyroid melanoma in pediatric patients.
Hello everyone, my name is Enas Ramel. I'll talk about a unique presentation of ectopic parathyroid adenoma in pediatric patients. Primary hyperparathyroidism is a rare disease in children. Here we present a case of a 13 years old girl who presented with abdominal pain. She had a history of recurrent acute pancreatitis. Also, her family history was positive for myasthenia gravis. Her lab investigation showed hypercalcemia, hyperphosphatemia, and elevated parathyroid hormone. CT, neck, and chest was performed and showed intrathymic ectopic parathyroid adenoma. Video-assisted thoracoscopic thymectomy was performed, preceded by a preoperative vitamin D injection to identify the ectopic parathyroid tissue during dissection. Patient had post-operative uneventful recovery and discharged home 48 hours post-surgery. Her serum calcium level also normalized immediately post-resection. Hyperparathyroidism may vary in the presentation, and only a few cases presented with acute pancreatitis due to hypercalcemia. In conclusion, ectopic parathyroid adenoma should be considered in any child with hypercalcemia. Video-assisted thoracoscopic resection is safe and feasible in the treatment of ectopic parathyroid adenoma.
Okay, very interesting. Thank you. Very quick one, please.
Yeah. Why stay in the left side? Did you go by the right side?
It's on the right side, as you can see in the CT. It's in the thymus on the right side. So right thoracoscopy.
Very quick, is your team a adult surgeon team or pediatric surgeon team?
Pediatric surgeon.
Good. So next.
So next is going to be Dr. Sofia Martinho. Thoracoscopic removal of thin cyst in pediatric age, please.
Good evening. So I present to you a thoracoscopic thymectomy in pediatric age. So thymic cysts are rare benign anomalies and most cases are completely asymptomatic. However, their accurate preoperative diagnosis is quite difficult and their management is not consensual. In this case, a 16-year-old girl presented with a suprasternal foreign body sensation and a visible mass with the Valsalva maneuver. Lab showed normal serum tumor markers and imaging studies suggested a thymic mass with around 4 centimeters with no signs of invasion. An ultrasound-guided biopsy was compatible with thymic cyst. Right thoracoscopy was performed in this presumable case of symptomatic thymic cyst. The anterior pleura was opened with care to preserve the left phrenic nerve and the internal mammary vessels. The cyst was carefully dissected, exposing the left brachiocephalic vein, and the inferior left portion of the cyst was preserved. The post-operative period was completely uneventful and the patient was discharged on the following day. Histological examination confirmed the presence of a multiloculated thymic cyst, and 1 year post-op the patient remains completely asymptomatic. So we think that thoracoscopic thymectomy is feasible and safe for thymic lesions, and after preoperative study the procedure is proposed especially for those who are symptomatic. Thank you.
The audience? No, again, same question. Have you been, some of the adult team was with you in theater with this?
Yes, a cardiothoracic surgeon helped in this surgery, the pediatric surgeon.
Thank you very much.
Okay. Next speaker, really exciting speaker. And you're going to talk about the usefulness of the 5mm stapler for thoracoscopic ligation of a proximal fistula in an infant with esophageal atresia and proximal fistula.
So I present to you the usefulness of a 5mm staple for thoracoscopic ligation of proximal fistula in esophageal atresia. And long gap esophageal atresia with proximal fistula is the least common type of EA. And thoracoscopy grants a better anatomic visualization, allowing for a more detailed dissection, including of these fistulas, otherwise difficult to identify and ligate. In this case, EA diagnosis was suspected antenatally and confirmed in the immediate postnatal period, and the presence of the proximal fistula when clinically suspected by the occurrence of specific respiratory infection was confirmed by a preoperative esophagogram, as we can see here. So a right thoracoscopy was performed, and after a careful dissection of the upper pouch, the proximal fistula was identified. A 5mm stapler was used to perform the thoracoscopic ligation, and then after careful identification and dissection of the lower pouch, an anastomosis was not possible, and an internal stage repair with internal traction was decided. 2 weeks later, an anastomosis was reattempted and not possible, so cervical esophagostomy was performed. However, the proximal fistula did not relapse. So we feel like in difficult cases with proximal esophageal atresia, a 5mm staple might be extremely useful and seems a safe and effective way for its successful thoracoscopic ligation. Thank you.
Very interesting. Questions? So, in my opinion, the 5mm stapler is very useful. We use it in recurrent fistulas. I've never used it in a proximal fistula. Is it? Can you visualize, because it's maybe high up in the thoracic aperture? Can you visualize well? Is it safe to use?
Yes, because the dissection was very thoroughly performed, and the distal portion of the fistula was clearly identified. Actually, this case of the fistula is not that high. We actually think that maybe the stapler might be even more useful, as discussed by Professor Rakowski. We agree, in even more proximal fistulas, where you have even less space to perform the suturing.
Okay, thank you.
Next is going to be Dr. Javier Lorenzo Montero, refractory artery in pediatric patient, T2, T4 bus sympathetic.
Good evening. Well, we're going to be presenting 2 patients that were operating in our center. There were 2 patients, one male and one female, that they had in background in the history. They had severe refractory pulmonary hyperhidrosis, and they have started medical treatment without response. So we post videos as the thoracoscopic surgery, bilateral sympathy 2 to 4. These are the critical steps in the surgery, which are the exposure of the sympathetic chain, the lateral extension of the sclerotomy, the canus fiber section, and the sympathetic chain release. And the main purpose of this work is to express that this is a standardized and reproducible procedure which can be performed in low-volume thoracic MIS centers as ours. We didn't have any kind of complications in our patients, but we have to consider the possibility of developing compensatory hyperhidrosis in this patient. Thank you very much.
Any question from the audience? Please, Fabio.
Only suggestion. It's very effective T4. Only T4 for hyperhidrosis. Very low level of compensatory hyperhidrosis. I suggest you to try.
Thank you very much.
The question, which one can be the worst complication in this procedure? Which one can be the worst complication in this procedure?
Well, the only complication we were aware about is the compensatory hyperhidrosis, but we performed an X-ray 6 hours after the operation, which was normal, and we didn't have any kind of complication. Thank you.
Okay, we continue. Next speaker is Francesca Nascimbe. Welcome. She will talk about pleural drainage versus video thoracoscopy debridement in children affected by pleural emphysema.
Good afternoon, everybody. I'm going to present my work, which is a multi-centric retrospective international study, which wants to compare the theranoscopic approach to the Mediterranean pediatric patients and the thoracic drainage. We involved in our study 70 patients, 30 female patients and 30 male patients with a mean age of 5 years old, and we divided them into two groups. We involved in the first group, G1, 12 patients underwent the traditional approach, so thoracic drainage, and in the second group, all the 5-8 patients underwent the VATS approach, with a mean operative time of 45 minutes in the first group and 90 minutes in the second one. These are our results. We had a post-operative fever of 5 days in G1 and 3 days in G2. A mean hospital stay of 15 days in G1 and 10 days in G2. Mean thoracic drain of 6 days in G1 and 5 days in G2. And the post-operative antibiotics requirement of 28 days in G1 and 25 in G2. 2 cases in the first group need a second surgery, and only 1 case in G2 need a second surgery. 33% in G1 have complications, and the complications rate in the G2 is 17%. So, analyzing our data, we can say that VATS approach could be considered a valid option to the thoracic drainage in the pediatric population too. Because the reduction of the hospital stay, the reduction of time of antibiotic therapy, and the reduced recurrence rate. So thank you.
Thank you very much. Any questions? Okay, I have a short question. So it's a retrospective study.
Yeah.
Do you know why the surgeon choose for the VATS and why for the drainage?
It was changing the approach during the period of reanalysis. So in the first 5 years, the approach is the traditional one, and then we decided to treat all the patients with the VATS approach.
So that makes it even more interesting to compare.
Yeah.
Thank you very much.
Dr. Federica Fati is going to present the laparoscopic approach of left accessory lobe associated with genital pulmonary and vein malformation.
Good afternoon. I will present a case report about the laparoscopic approach of left accessory lobe associated with congenital pulmonary malformation. Our patient is an 8 months old male with prenatal diagnosis of congenital pulmonary malformation. The CT scan at 3 months show the pulmonary malformation of the upper left lobe well outlined with a liquid content, no systemic vascularization. A minimally invasive thoracic approach was performed, and during surgery, the lung malformation completely apart from the upper lobe with its vessel and bronchus was found and completely removed. The pathology report described an accessory lobe with C. palmum type 2 based on Stoker classification. To our knowledge, this is the first record describing this association in the children. Thank you for your attention.
There's no time, so there's plenty of time for questions from the audience. So, do you think a different imaging approach would have done any difference in your treatment? Like 3D reconstruction would have been?
So I think that there is an indication for surgery because there are risks for infection also. But we previously discussed the imaging with the radiologist and we did not find any signs. So I think that probably it could be a good choice for the diagnosis. Thank you.
Any other questions?
Okay. So next, Isabel Vada-Bosch. Thoracoscopic pericardial window, how to approach pericardial pathology in the pediatric patient. Review of the literature.
Good afternoon. We present a case of a thoracoscopic pericardial window creation. Our patient is an 11-month-old female with a chronic hepatic pericardial diffusion that has been non-responsive to conservative treatment. Therefore, a pericardial window was advised. Under general anesthesia with a tracheal intubation and a right bronchial blocker, we perform a right thoracoscopy. The patient was placed in a supine position with the right arm elevated, and 3 trocars were placed, a 5 mm trocar in the fifth intercostal space in the medium axillary line, and 2 3 mm trocars in the anterior axillary line in the in the third and seventh intercostal spaces. The procedure is pretty straightforward. The pericardium extraction, and then with the scissors connected to a monopolar source, we perform a pericardiotomy. Then it is we create a bigger window until a sufficient size is acquired, and taking care not to injure the phrenic nerve. The postoperative course was uneventful, and the patient was discharged on the second postoperative day with no complications, and after a 2-year follow-up, she has not presented any recurrence or complications. Therefore, we conclude that the thoracoscopy can be the right approach for pericardial pathology in children. It is safe, it is minimally invasive, and it has excellent exposure of all the pericardial surface, therefore reducing the risk of recurrence in this type of pathology. Thank you.
Any questions?
How do you decide this? Do you decide the site of the thoracoscopy? This is one question. And one suggestion. The monopolar has some more risk of the arrhythmia. Do you consider to use another therapy device? For example, a harmonic physical or something?
We actually use the monopolar source because we have more experience in order to open a ligation, which is more expensive, but
has more risk of the arrhythmias.
Yes, it does. But with the right monitoring and the appropriate coordination with the anesthetic team, we didn't have any problems. And when you said the site
of the
site or the size?
Site, which site?
Well,
right or left?
We usually.
How do you choose your site?
We chose the right side because the cardiac team told us it was better to make the pericardial window in the right side, actually. Not because of any I mean, we didn't have any other. They told us that the right side is better, and we did it that way.
Thank you very much. Thank you very much. So let's carry on with the summary of the section, selected findings, Dr. Jonathan Eichner of Bristol.
Dear Chairman, dear colleagues, I would like to present 4 cases of pulmonary sequestration for acute section patients. It were aged 2 days, 6 years of age at the point of operation. 3 out of 4 were diagnosed with pulmonary sequestration prenatal. Basically, nowadays high-resolution imaging is available, but we experienced that clear limitations were mimicked and that the exact characterization of pulmonary sequestration was not possible. Therefore, it is very important to keep careful step-by-step dissection of pulmonary sequestration. Some people still advocate a conservative treatment. We had a case where atypical clinic was misleading the therapy, and the chronic infection was leading to severe adhesions, which made the operation more troubleshooting. When you think of pulmonary sequestration, you should always think of other etiology, as for example in our case, liver tissue. Previous operations are not limited effects for a thoracoscopic approach, as we saw in one of our patients.
So, thanks for your presentation. So you're perfectly on time. So, any questions?
For the thoracoscopic approach, also for the liver one, for the liver sequestration.
Yeah, exactly. We had for the liver tissue, we saw that it was on the X-ray, and we saw that it would be a typical findings of an extrapulmonary lung sequestration. Okay, it was no connection to the liver at all. Okay, so we took the normal approach, and just with the histology, we saw that there was liver-like tissue, islands of tissue like you find in the liver cells.
And when you look into other literature, there is always a connection to the liver at some point, like there is a strain or there is like some blood supply, which is giving you a hint that it's maybe not a pulmonary sequestration. But we didn't find it at all.
All right, next, we're going to talk about successfully elective thoracoscopic dissection of complicated extracellular bronchopulmonary sequestration after intravenous vascular laser ablation case. Giulia.
Present the case of a female fetus with a diagnosis of a left thoracic mass, pro-intestinal sheath, and aside she underwent to successful intrauterine ultrasound guided laser coagulation, and pregnancy proceeded without other complication. She was born at term with a poor upper score and respiratory distress requiring mechanical ventilation. A CT scan confirmed the presence of a residual mass and left thorax. So she was closely monitored, and when she reached 10 kilo of weight, she underwent to a elective thoracoscopy. We found a partially viable mass with the feeding vessel originating from the abdominal aorta that were divided with the hemorrhage and divided with the ligature. The adhesion we found were gentle, were smoother, and the dissection was easy. So for conclude, the thoracoscopic excision of residual extraoral sequestration after intravenous coagulation is feasible and not always associated with the presence of severe